Welcome to Amazing People number 9. This is my guest, Dr. Ravi Shridar. He is a radiation oncologist in Orlando, Florida, and we're going to talk about everything from being a doctor to his life to habits and probably some things that are going on within the world and society. So I hope you enjoy it as much as we're going to enjoy filming it. Welcome.
Thank you for having me. Yeah.
Thank you. So can we start with a little bit of a biography, a little bit of an introduction? Where do you come from? How did you end up in this position where you're a radiation oncologist and sitting here with me now?
Okay. So both of my parents are academics. They emigrated from India. Initially, they moved in Canada. They both took jobs at the University of Windsor. My dad is a professor of engineer. My mom was a biologist at that time, just got her master's. And I think as the job market started to flourish, and we were on a border city, Windsor versus Detroit, so making a move from one country that wasn't a big location change, but it was a big culture change. But my dad ended up taking a chair position at the University of Michigan Dearborn, teaching engineering. Mom ended up getting a technician job at Wayne State University. She eventually enrolled in the PhD program and ended up getting her PhD. But one of the things was that I knew I was probably going to do something academic. That's just kind of the culture that we were in.
Academic or STEM?
Academic STEM. So,
Okay.
Whether it was engineer or biological sciences, it was probably going to be something in the academic world, university world. And so I did, and just, I spent a couple of weeks with my dad working in his lab and working with his colleagues. And the engineering thing just didn't click with me. Then I spent the next couple of weeks going to work with my mom during the summer, and I just loved it. And so I took a real interest in it. And so I was always, so during high school, I would do summers working in the lab there. I would initially was washing dishes, and there is a proper way to wash dishes in a scientific lab. And then as her bosses kind of saw that I was interested, they kind of mentored me and fostered me, and I was starting to do helping them to set up simple experiments and that sort of thing, and that just grew my love for doing kind of the bench side research.
Were you intentional in taking that lab job? Like, was this a thing that you were hope would help you get into a medical thing?
I think
or
that's
more organic.
Yeah, I think growing in the era that I grew up in, basically kids of Indian parents either went into engineering or they went into medicine.
That's the same case in India too.
There was nobody going into law. There was nobody going into politics. Unlike you, and there was nobody going into acting. And now you see today, it's just they're tackling every industry.
Well, they have
head on in business, especially business and politics now, very vigorously. But there's still, even with all that said, there's still the number 1 and 2 driving careers for Indians is engineering and medicine. And I think that was the case with me. And so I was like, I didn't fall into the engineering camp. I fell into kind of like the medical camp. So I kind of knew I was going to be a doctor. And then it was just trying to figure out, well, what exactly do I want to do? My mom worked in basically a cancer biology lab. And so I think just from that initial upbringing, I think I knew, okay, I'm probably going to do something cancer, but I don't know what. I didn't know if I was going to be a surgeon. I didn't know if I was just going to be an oncologist. I had no clue. Ended up going to Wayne State University. Ended up getting a full,
Where's that?
In Detroit, Michigan.
Okay.
I ended up getting a full ride, and because I was taking classes there, I was able to work in the lab longer hours and actually starting to do real experiments. And actually during my undergrad, because of all the great mentoring I got, I was able to actually get my name on 6 publications, which at that time was pretty impressive for an undergraduate. That kind of drove me, and that made it, I ended up getting into medical school probably because of that. I'll be the first to say that I'm probably one of the lousiest test takers growing up, which is unusual for probably most Indian kids. But my MCAT scores
maybe for most doctors also.
Yeah, possibly, but my MCAT scores were average at best. But I had this drive and passion for the scientific research, and I think at least being able to get that interview, I think they were able to see that, and they gave me a chance. And then so I ended up going to Wayne State, ended up doing a combined program, MD and PhD. So my 4 years of med school,
okay.
So my 4 years of med school turned into 8 years of medical school. I ended up getting a PhD in a cancer biology lab, and again, I still didn't. I understood the research component of all of this stuff, but understanding the integrating all of that into the clinical world was still, lost on me. So when I got back into when I finished the PhD and then continued back into medical school, this was now doing all the medical rotations. So I really had a chance to see, okay, what are the main questions being asked, and is our research really answering that question? And it was about 50-50. I think at that time, the genome had just been sequenced, and so all of these kind of personalized medicine and molecular profiling that we do routinely today was just at its infancy then. And no one knew what to do with it. And then everyone's like, well, what if you have it? What do you do with it? How do you tell the patient? How do you tell the patient's family? Is this genetic?
About what?
If they have genetic mutations that are driving their cancer, or they have certain molecular profiles that indicate that they're going to respond or not respond to therapy. So I ended up doing rotations in medical oncology, and I focused heavy on the cancer world, maybe to my detriment.
Why? Because you're specialized.
I was specialized, but when I was so focused, I'm like, I want to get to know everything about oncology, and I think I lost some other aspects of what medical school training is supposed to be about, being trained as a whole doctor. I think a lot of the stuff that I kind of passed along now, I'm kind of trying to relearn now because I see how much it's integrating into my clinic now. So I'm actually going back and relearning a lot of those things that I don't have a heavy hand in the clinical decision making, but they certainly impact the quality of life and the clinical outcomes of my patients. So I ended up doing rotations, heavily focused on medical oncology, surgical oncology, radiation oncology. And the two things that I really fell in love with were radiation and surgery. The problem was I was already so starting to go into burnout a little bit, being already 6-7 years into schooling. And then I had to look and see what the rigors were of these two fields, and radiation oncology at that time was highly competitive. Fortunately, I had a lot of research, a lot of publications, and that's kind of where radiation oncology was going, and they wanted more of these kind of research focused residents. And I looked at surgical oncology as well, and the lifestyle then was very rigorous, doing 5 years of general surgery and probably another 1 to 2 years of surgical oncology. I was looking at that as, it wasn't that I didn't have the interest, I was like, do I have the energy to be able to do that? And then you look at radiation oncology, it's basically, you start specializing in oncology from year 2. You do 1 year of internship, and then you're 4 years of just straight out oncology. So you're specializing immediately. Lifestyle is definitely better. And I don't want to say that that's really what impacted my decision, but I had to weigh all those factors to say, what am I actually going to get through this? And I said, I think I can get through the radiation. And fortunately, because of my research, that did score me some interviews that maybe I shouldn't have gotten. I finally got better at taking tests and actually had really decent board scores that allowed me to be competitive. But I ended up getting into Wayne State radiation oncology program, so I did complete that. Now, at the time, I needed to figure out what exactly I was going to do. So do I want to stay in academic medicine? Do I want to specialize? It seems that if you really want to make a name for yourself in academic radiation oncology, you have to pick 1 or 2 disease sites and really focus on them and learn how to treat that and become an expert at that and start to publish that. So I really had a strong interest after doing all my rotations in radiation oncology in the GI world. I thought that was gastrointestinal oncology. So that includes anything from esophagus, stomach, pancreas, bile duct, liver, colon, rectal, and anal cancer. And I was like, this is just, you're a specialist in GI, but you're also going to know 10 different disease sites just from seeing all these patients. And so when I was looking for jobs, there were two academic jobs that were available that were allowing a GI focus, where basically you were only going to treat GI oncology patients. And after it was all said and done, I ended up choosing Moffitt Cancer Center, and they did hire me in 2009. So I spent 2009 to 2014 at the Moffitt Cancer Center. Had a great mentor there, Sarah
That's
Hoff.
in Tampa, right?
That's in Tampa.
Yeah. I've heard of it.
Yep.
Yeah.
And I was treating just GI oncology patients. My mentor and I helped to kind of advance the program, integrating new and novel radiation techniques like stereotactic radiation therapy for pancreas, using radioactive glass microspheres to treat liver cancer. And so this really kind of put us on the map. We were getting invited to give talks. We were publishing a lot. And as with all institutions, they kind of go through this kind of rollover. There's frustrations and people leave, and an opportunity arose here at Florida Hospital, now Advent Health, at the time, where they were replacing their entire radiation oncology program to become more academically focused in a private practice setting.
As opposed to clinically focused.
Well, yeah, to focus clinically, but they also wanted, to hire doctors that were interested in doing research, because they had a research institute that we were trying to collaborate with, and the Cancer Center was trying to go also more towards this, being able to do research, clinical trials, working with the pharma companies to do that. So that lended a nice opportunity for me to experience private practice, but being able to bring kind of a research kind of academic approach to it.
What's interesting about that is that I don't know that much about the medical system, but it sounds to me that a hospital that would end up opting for what this one opted for, making it more academically focused, when they are a private practice in the business of doing clinical work, that leads to a dynamicism that it would not have otherwise.
Correct.
It's more difficult to master and accomplish, to figure out how the doctors will spend their times, how to integrate this research, but putting it in that context rather than just getting research from universities and other organizations.
And it's funny that you say that this hospital is now embracing that, and what we were kind of seeing, and it wasn't just at Moffitt, this was kind of going across the country, is that in academic medicine, you have a lot of protected time. I had a lot of protected time. I only had about 2.5 days of clinic. I got a lot of time to do research and other activities like that. That was starting to go by the wayside, with all the changes in the reimbursement patterns, with the insurance companies doing what they were doing. Hospitals and even academic centers were probably end up collecting a lot less revenue. And so they were starting to make their doctors work more and more like you were in a private practice, and taking away some of that protected time. And so we make a lot less in academic medicine, but if you're going to make me start working private practice type volumes, and not give me the protected research time, and I now have this opportunity where I'm going to probably get more private practice type reimbursement, but they're offering me more opportunity to do research and clinical trials.
It's like they're offering you what you wanted to begin with.
I wanted to begin with. So it just seemed like the natural fit, and so we've been here, and we've grown the program nicely, integrated well with the surgeons and medical oncologists. I think they're happy to have us there with this kind of more disease site focus, because now they feel just very confident always referring patients, because they know they're going to get they know that we're going to be up to date on the most modern treatments and the most recent published studies. So I think, and it's not just the radiation program. They've been doing this in the medical oncology program, even in the surgery programs, and so this has kind of been kind of a system-wide thing in that cancer center, and so it's worked really well.
You mentioned that you didn't have the best grades. And
I had good grades. I wasn't the best test taker.
You didn't have the
My
best.
standardized test scores were average, probably at best.
So you weren't the best at that.
Right.
Yet, because of drive and interest, which showed in interviews and so forth, you were able to get to the position that you're in.
Yep.
I think when people look at doctors, especially ones that are in high positions, they view them as these sort of like people who have always been on the nose, always been bookish, because of course the amount of study is extremely intensive and it's regulated by tests. I mean, not necessarily standardized tests, but medical tests, because you can't have someone who doesn't know everything,
Right.
in this position.
Exactly.
The certification degree is of a very high degree. But anyway, you're a human, and all the doctors are humans, and they're probably more like you, who were not the best at standardized tests, or maybe they weren't the best at memorization, but other aspects of them ended up filling in the hole. And maybe those aspects that they weren't good at ended up getting better. So could you comment on that personally? What was that like?
Yeah, it's very interesting. Like when I first started residency, my first 2 rotations were with the 2 busiest doctors in the practice, and you had to learn quickly how to navigate and manage a large patient load and get notes done on time and all the documents and tests in order. So basically I got thrown right in the deep end, and it was like sink or swim. And fortunately the clinic was very well run, and I was able to grow and catch on how to be efficient in the clinic. That right now is one of my very big strengths.
What?
Being able to see a patient, evaluate the patient, get them in quickly, get them started quickly, and without a lot of delay. Now, sometimes the delays are from insurance, and our hands are tied by that. But even with me, I have one of the most busiest schedules in our group. Yet I'm still, I think we've got the clinic working in such a way, and I'm able to still accommodate when the head of the cancer center says, "Hey, I got this patient here. Can you get him into the clinic? He needs to get started soon." It's like, all right, send him down. Barring any insurance issues, send him down. I'll get him in. We'll get him worked up. Don't worry about it. I think that's one of the strengths that has really grown in me. Now, even when I was at Moffitt and I only had 2.5 days of clinic, I was never really drowning. Things got done. I learned to get things done quickly, just so that I could get back to going doing my research thing. But I never turned down a referral. I never turned down an add-on patient, even if it was near the end of the day. You build your reputation and your practice's reputation on keeping the referring docs happy. And at the same time, not just getting their patients in, but making sure they're getting high quality care as well, and in an efficient manner. And there's a lot of coordination that has to go on with oncology, coordinating start with chemotherapy, with radiation, doing it, making sure that, if it's done in a preoperative manner, to make sure that you call the surgeon and get them in so that they can be evaluated preoperatively. You don't want to wait too long. There can be potential complications. So communicating with referring docs is one of the big key things, I think, to keeping a successful practice, especially in this age of multidisciplinary care, where they're getting everything, right? They're getting chemotherapy, radiation, and surgery, and they all have to be integrated and managed efficiently.
Who makes these decisions then?
So it depends. Yeah, it depends on what treatment is being delivered at what time. So let's say someone is starting with chemotherapy, then the medical oncologist is going to control that. But then let's say they're coming for radiation therapy, then I have more of say in what's going on, because I'll know when the patient's going to finish their treatment as I'm evaluating them weekly. And then so once I know they're getting near the end of treatment, boom, I'm making the calls to the surgeons, and not just saying, okay, telling my scheduler, hey, he needs to see so-and-so. I'm calling the docs themselves, shooting them an email, as well as their PAs. And so that's also the key. If you know their PAs, get to know their PAs, because their PAs will get them in a timely manner as well. Even double booking, because the schedulers are limited, they're not allowed to double book or triple book, but the doctors can say, yeah, just allow that. So that's one of the keys is communication. being efficient in the clinic, but not efficient in the clinic where you're spending 5 minutes with each patient, but knowing what you're going to do and what you're going to say before you even see the patient. So one of the big things is doing clinic prep, looking at everything that's been done, reviewing all the images, reviewing the pathology reports, looking at everything, and then making sure that this is that this patient fits what you're going to recommend. So the minute I walk in, I do my history, verify everything, and then I already know what I'm going to do. I already know what I'm going to do before I see the patient. Sometimes I'm doing clinic prep 1 or 2 days in advance, because sometimes I know I need off, sometimes I know I need some things.
Is it fun sitting there planning it?
It's not fun. It's very tedious at times, and it keeps you sitting rather than moving. But this is necessary to be able to run an efficient clinic, especially if you want to manage a large patient volume and coordinate all this multidisciplinary care. It does take hours. So sometimes I'm coming in at like 6 or 7 o'clock in the morning, reviewing all the patients' stuff, so that when I know they're coming in, I know what we're going to do. Sometimes the visits are quick. It's like, hey, your scans are great. You're not having any side effects. Let's see you in 3 months. They're like, yay. They're happy about it. Other times you got to spend an hour. It's like, okay, yeah, so you have a recurrence. This is what we should do. So that's one thing, that efficiency doesn't necessarily mean just go in and get out, but going in knowing what you're going to do, not trying to figure out what you're going to do, and that helps to get patients going much more efficiently.
So it takes a lot of discipline and work to get to a high rank in many professions, right? Or in many studies. Like if you wanted to be Einstein, that's tough.
Yeah.
If you want to be a doctor, that's tough. If you want to study law, that's tough. The degree of impact of those respective careers, or any careers, is different though, right? As a doctor, you are literally in the one-on-one capacity of doing things that will save people's lives. Essentially, every person who comes to you, they come to you because they are sick and have cancer.
Yeah.
Which they're probably going to die from if it's not treated.
Right.
And then you step in, and then however many months later, they're better or they're healed. Your job is to make them better. Right. How does that figure into your motivation when it comes to coming in at 6 or 7 in the morning, all the studying through many years and training and so forth?
So that's kind of a multifaceted question. So when I'm seeing somebody, like let's say I'm seeing somebody with an early stage lung cancer that can't get surgery, I know there's an 80% likelihood that I can treat that tumor that they have successfully with a very non-invasive, quick course of radiation therapy, minimal side effects. So all day long, I could say, yeah, I feel good about what I'm going to do with you. Now, on the other end of that spectrum, and then it's same thing with like anal cancers. Anal cancers, we cured 90 to 95% of them. But what I do tell them is it's one of the most miserable treatments you'll ever go through, and I'm going to have to hold your hand, but that's what these next 6 weeks are going to be, is me getting you through the treatment. You're going to hate me at the end, but in 3 months, you'll be cured.
You'll love me again. You're like a tough high school coach.
Yeah.
Yeah.
And I think they do appreciate the bluntness, but I do. It's not even just being blunt to be blunt. They need to know what they're going to go through. It's like, yeah, we're going to cure your 95%, and then all of a they're going through the treatment. It's like, hey, doc, I'm miserable. I can't go to the bathroom without feeling a lot of pain. You didn't tell me any of it. You need to. So I tend to sometimes overstate the side effects a little bit, but other times I know that side effects is not going to be an issue. But if I think, you can sometimes eyeball a patient like, hey, I think you're going to have issues, then I spend a lot longer. So anal cancers, early stage lung cancers, some other types of cancers that we can do very well with, I don't lose a lot of sleep over. It's the let's say we're treating somebody for rectal cancer that we needed to shrink the tumor so that they can save the rectum, and the response wasn't as good.
That's different from anal cancer.
And that's different from anal cancer.
Okay.
So the rectal cancer is a different entity altogether. Mm-hmm. It always needs surgery. Anal cancer, 95% of the time, never needs surgery. And you're trying to tell them, look, the treatment didn't work as well. You're likely going to need the permanent colostomy. That's a very tough conversation to have with the patient. Similarly, pancreatic cancer.
Is that what Steve Jobs died of? Or was that prior?
He did die of pancreatic cancer. He died of the neuroendocrine type. This is the type that you can live, 5 to 10 years with. The other type, people live 2 to 3 years with on average. And most of the time they require preoperative therapy. I tend to see them later in their treatment. Usually they see the surgeon. Surgeon says, no, I can't operate right now. I can't get it all out. They'll send you to the medical oncologist. He'll start you on some chemo. They get chemo, and then they'll rescan, and then the surgeon will say, yes, I can take you, or no, I think you still need more treatment. That's kind of then when I see them at that kind of third stage, and then I'll evaluate them and right now I can say, look, I can offer you a very aggressive, short course of treatment. Instead of the traditional 5 to 6 weeks that we're doing, I can treat you in 5 days. And then I'll tell you, but in 1 month, when we repeat your scans, your tumor is not going to shrink at all. And they're like, well, why are we doing this? Well, it's like the surgeon is still going to probably attempt to remove it after the radiation, even if it doesn't shrink. And he'll have a 50% likelihood of getting it completely out. If he's not able to get it out, I can say that the tumor will still be controlled and not grow for at least a year in 80% of patients. So that tumor is going to be controlled and not cause you any problems for that period of time. And then they're like, well, what happens if it grows after that? And then that's when I'm like, well, we'll have to probably start you on chemotherapy again and, monitor you very closely and that sort of thing. With the pancreatic cancer patients, I tell them right from the get-go that the likelihood for an advanced cancer that can't come out because the surgeon says so to all of a sudden now become resectable is only about 10 to 20%. In some cases where it's maybe less advanced but still a high risk for not being able to get it out, that's about 50%.
What's that conversation like?
So I tell them, I said, look, it's a 50-50 shot. If the surgeon can't get it out, we're going to continue to monitor. We may recommend doing more chemotherapy. What I tell them now is, now that I'm able to offer you this 1 week treatment, it's not that I put you through 6 weeks of treatment for nothing. We're doing this 1 week treatment, which I think is as effective and more likely to control the tumor, and you'll have a lot less side effects from the treatment. But it's not going to shrink for at least 3 or 6 months. And then when I bring them back for 1 month and I said, well, the tumor's stable, nothing changed. And they're like, what? I'm like, remember what I told you yeah, you did. And then they're like, oh yeah, okay, you did mention that. So I'm like, I'm not surprised by this. This is kind of what we want. And now it's up to the surgeon to see if he can take it out. So I kind of toss it back to the surgeon, but then if at that point, my role is really limited, but I still follow them for side effects. I'll give you 2 examples. Like I treated one patient 3 years ago with this 5 treatment. He wasn't healthy at all for surgery. He got his chemo. We did the 5 treatments of radiation. I saw him a couple of times, and then basically he just continued to follow with the medical oncologist. The scheduler about a month ago said, hey, there's this patient here. He wants to see you. Can you see him? I'm like, who is it? So I type his name, like, oh, that's the patient I treated 3 years ago. It's like, wow, what does he want? He goes, oh, he just wants to thank you. He's like been disease-free for 3 months, for 3 years now. And his last set of scans look great. I'm like, yeah, throw him in the room. Let me go talk to him. So that was very encouraging. But also last year, a patient that I treated in the summer, I got an inpatient consult. He was admitted to the hospital, and 3 months later, and it turned out because of the treatment, I ended up causing a severe ulcer that perforated his stomach, and he needed surgery to correct. And then also at that time, his cancer had spread to the liver too, so he had a very aggressive form. So he had he had progression of disease as well as complication related to the treatment. I sat down with them, had a very long conversation. They were actually, interestingly, saying, very thankful that I was able to treat them and see them and potentially consider additional treatments for them. And it was like, we knew that this was a possibility. You told us. We don't blame you. We know that this was an issue. But that's the bad, right? You think you're giving the best treatment, you're giving it, but then you cause the complication, and that's always what we try to avoid. That complication is on the order, fortunately, of only 5%, but unfortunately, someone's going to end up with that complication. So,
I interviewed Dr. Garganos several months ago, and he said that when a doctor makes a mistake with the patient, or if the doctor can't save the patient, or the negative news needs to be given one way or the other, if you sit with the patient and look them in the eye and you speak the truth to them, they understand.
Yeah, and I have to agree with that assessment. And it's hard. You get the results and they're in there, and you're like, okay, so I'm going over, and that's another thing. I'm like going back and making sure everything I did was on par. And then I go in and then, sit down with them, chat with them a little bit, find out how they're doing, find out if they've seen the results of the scans, and then slowly go into it. It does take a balancing act. I've had most patients are very understanding. They know that some bad news is going to happen. I've had one patient that was so angry he just burst out of the clinic, slammed the door. And that's also it's not an improper response. I mean, you're telling someone, hey, look, I can't treat you, or the treatment didn't work, and you really literally have like 3 months to live. That's not an easy conversation.
It's existentially horrifying for the person across across the room.
Yeah. And they during med school training, residency training, you learn how to do patient interactions, but until you're out in the clinic yourself and they're your patients, everything you learn basically goes out the window, because now this is your clinic and you have to figure out how you're going to proceed. So my thing was, I want to be upfront, not brutally honest, but I want to be upfront, let them know everything that can happen, let them know the potential outcomes. Like, I'm usually the first one after like 5 or 6 doctors that they'll say, well, what's my prognosis? What's my likelihood of living? And I'm like, I'm going to quote you statistics that apply to 100 people, and I can say, at 5 years, 30% are still alive. But I said, when it comes to you, it's still 50-50. We have to do the treatments. If you have a very good response, you're going to live a lot longer. If you don't, your prognosis is dim. And that's also one thing they don't kind of teach you in medical school and residency.
To tell someone that they're going to die.
You're quoting statistics. Statistics apply to a population. The individual, it's always 50-50.
Do you think that, so there's the science aspect, and how people talk about, like, you need to believe something to make it true, right? When it comes to treating patients, so this is science and biology and some force of life, because there's life within that body.
Right.
And when the body dies, the life is gone, it's a dead body. Do you think that there's some aspect of, if you as the oncologist and your entire supporting staff and every other person in the medical arena that this patient encounters, if every one of them really believes and really puts that this person can live longer, the treatment will work, and they put every aspect, they do the work with more care, and does that belief aspect, can it end up making a dent within the statistics and change the statistics?
Certainly when there's a lot more hands-on care, like with clinical trial patients, they do tend to perform better than the average patient that we just see in clinic that may or may not be eligible for that trial.
What's clinical trial?
So when clinical trials are done, these are testing different medicines, testing different ways to treating, and so basically in a randomized fashion, patients will either be assigned to the standard of care arm or to the experimental arm, testing a new drug or a new way to treat. These patients that are in clinical trials are heavily pre-screened, have to have very minimal medical issues, be able to basically be evaluated to see if the trial doctor can think they can complete the treatment. And in reality, the average patient we see probably never fits that clinical. There's a good proportion of patients that we see that don't fit, that would not be eligible for that trial, but we have to use that trial to treat them because that's kind of that'll be our new standard of care.
Oh,
So
but since they're not selected randomly enough, that's why they have better results.
Right.
Okay.
So the average clinic patient is probably not going to do as well as a clinical trial patient who's screened to be a better performer.
Yeah.
And so there is bias in that, and we're aware of that, and we always look to see, this patient is on 6 liters of oxygen, can barely walk up the flight of stairs, is on the couch all day, she's likely going to die of her lung disease. Do we really want to give her this standard of care treatment even though it's indicated by the trial? And so we have to make those decisions every day to treat or not treat. That sometimes the treatment is worse than not treating.
Mm-hmm.
And so, you really only learn these things by running your own clinic or being in the clinic and taking responsibility. There's a lot of things in training that I think are lost, and that's basically we're spending so much time just trying to learn how to treat,
mm-hmm.
and learn why we have to treat, that there's so many other aspects of clinical management that are in play, like what's the patient's social situation, can they get to treatment, do they have transportation issues, are they taking, like I have had patients that say, I can't get any treatment right now, my mother is dying, my wife is dying, I have to spend a lot of time taking care of her, and I can't just come and do these treatments. And it's like, what do you say to that? You're like, well, if you don't get the treatment, you don't say if you don't get the treatment you're going to die, but you have to be understanding of that situation. And sometimes it works out, and sometimes the cancer does get worse because they haven't gotten treatment. These are issues that on paper in clinic prep everything looks great. You go in and see them and talk to them, and you see all these different aspects that they have to deal with, and then I can treat anybody on paper. But once you've seen them and evaluate them, then you can say, okay, I understand the difficulties in the situation. Let's see how we can get everything coordinated.
From a human perspective, because there's Dr. Shridar, the doctor,
mm-hmm.
and there's there's Ravi Shridar, the person, right? What's some advice you would give yourself if you could look at yourself 20, 30 years ago and say, would it be stop worrying, kid, or would you have chosen another profession, or what is some major thing that you wish you'd have done differently?
So when I was going through schooling and training, my one goal was to get done as quickly as I can. I kind of pushed everything off to the side. I mean, I had friends, I went out and did all that things, but I didn't take on doing international clerkships or anything like that. I didn't want to delay. I wanted to get done. And I think I lost out on a more global perspective because I was so, I want to say narrow-minded, but I was so focused on the end goal. When
you say global, you mean like global in terms of your life, or literally global?
No, like
literally,
both.
like traveling the world.
There's a world out there,
yeah.
And if all you're seeing is this, then you're probably missing out. You're not seeing everything. The way they treat in Europe is probably a little bit different than the way we treat here. And all these Doctors Without Borders, when they go and do all these basically treating outside of a clinic and all that's something amazing. But I think.
Have you met those people?
I have, like during training and internship, we had doctors like that, and they have amazing stories to tell, and you can see how that helped shape them and who they became. And I think just getting the end goal, getting the degree, which is important, and that should always be the end goal. I think also how you get there matters. And I think I took such a straight path instead of veering off and experiencing other things, that if I had to go back and tell myself, go travel, there's a world out there, and you don't know anything. You know what you know in your backyard. And
does your job preclude you from traveling now?
Oh no, I do travel. In fact, I travel a lot more now. There's meetings all over the world. Meetings. No, but we do have the opportunity to submit and present at these meetings, and they're usually and they are all over the world. Like I just came back from Rome, and that was my first time in Rome, where I did present at a meeting there, And
Do you see the stuff when you travel? Like, do you go and you like? Did you see the Mona Lisa's in Florence, right? But did you see the Vatican?
I saw the
Did you
Vatican,
see...
saw the Sistine Chapel, saw the
How-
Colosseum. That was just like, I was just like, what have I done? Why didn't I do this earlier? And so I've been hitting with the travel bug, just kind of see the world, also experience the different cuisine. I like my new thing is if I go to a new great city, I try to eat at a Michelin star restaurant. Just it's an amazing experience. Rome, just when I left Rome, I felt empty. I mean, I was like, this was just amazing. And so I think the advice I would give myself is, take a little time, go travel. I wish I would have taken maybe even a year to go do something like that. Because I think that does, just even if it has nothing to do with your career, just seeing that, just like now I have all this great interest in like Roman history, and I watch the History Channel all the time, and they have all these shows on Roman, and that's like my new TiVo thing.
Yeah.
So just from that aspect, it changes you as an individual, and I think it makes you more whole. Mm-hmm. You can be the best doctor, and if that's all you do is you read journals all the time, you treat patients, and that the meetings you go to, you're very serious. That's great and all, and that's what the patient needs. But there's an aspect of you that's probably missing how to connect with the patient, because they all come from different parts of the world, different areas of life. I think that for me, the one thing I would go back and tell myself is go travel, take a little time. You're gonna get there. You're gonna finish. You don't have to finish in 3 and a half years. You can take a little time, even if you take 4 to 5 years. You'll be much better for it. You'll be a much whole person for it too. And I that's one of my big regrets growing up.
So you talk about meetings around the world,
Yeah.
right? So there's probably millions of doctors around the world, and everybody has this idea of, I mean, you obviously you want to treat patients, right? And that's the job that you have. And I think that most doctors would like if, though they may be out of a job, if this were to happen, that there was no diseases, right?
Yeah.
Is there, or that there would be cures, like a cure for cancer rather than a preventative or whatever your type of treatment? Given AI, given technology, given these international meetings, and given what you've seen from your now global perspective,
Right.
Where are we headed
So,
with regard to the treatment of cancer, HIV, maybe
Right.
other diseases, health in general?
The HIV docs really have to be commended. I mean, they basically started from nothing and basically turned that into a deadly disease into basically a chronic disease that just needs to be managed with oral medication, because they have 4 or 5 drugs. Then they've done an amazing job. Cancer's tried to take that same type of route. Unfortunately, early on, it didn't quite have the same success. Now, given the technological advances of being able to sequence a whole genome in a relatively short period of time.
What does that mean for a layperson?
So,
which means me.
The whole genome project was to sequence the entire human DNA to know what the sequence was, what mutations were there, how it coded for proteins, and how it makes the cells function and why we function as humans. Taking that perspective specifically to cancer, where all of that is kind of messed up, has really dramatically increased the availability of new treatments that can specifically target a specific mutation in a cell. Minimal side effects, an oral medication that can be taken and having stable disease for years. There's a number of these drugs. I think the biggest, obviously the most impactful thing in the last few years has been immunotherapy. Basically, it's a drug that's given IV, and it basically turns off a negative regulator of your immune system or turns on a positive regulator.
Is this for like HIV or
no, it's for cancer.
Okay.
And basically retrains your immune system to help fight the cancer. And that's been very highly effective. We're now studying what's the role of radiation in terms of the immune system. We know that radiation itself is very inflammatory. It can stimulate the immune system. So we're seeing actually synergistic responses by combining radiation and immunotherapy.
Which cancel each other out in a way?
No,
Or?
they enhance each other.
Okay.
They can enhance the response. So there's that. I think, ultimately the goal is to get through to the most ultimate personalized medicine delivery. So they'll take your blood, they'll take a sample of your tumor, they'll sequence it, they'll understand all the DNA and all the mutations. They'll be able to say, this is the treatment we need to give you specifically. And I think that's kind of where we're heading. AI is definitely having an impact. Even at the last radiation oncology meeting that I went to in San Antonio this year, one of the big talks was on AI and how they can help radiation oncologists get more standardized planning and delivery of radiation oncology. And this is importing hundreds of thousands of plans and letting the system kind of come up with a plan, and then they've compared it to other doctors' plans, and it's not too far off. I think that's kind of where we're kind of heading in the future.
Who runs the AI? Is it Google and Facebook?
I think they're
companies?
working with it. There's other private companies that are kind of doing it right now. I think Google is trying to probably does have a hand in it, but I think right now there's a lot of private companies that are kind of doing that. The big thing that I think is going to be the take home is that the increase in cancers in young people today.
Is that because of food or phones?
And that's
or
what I think is the big key. It's
hormones.
I think it's nutrition.
Okay.
I'm 100% like just what you said. I think it's what we eat. Like in patients less than 50, and I've been seeing a lot more 30-year-olds and 40-year-olds with stage 4 rectal cancer. You got to wonder about this whole gut microbiome and the probiotics. What we eat, is that helping our gut bacteria, or is it hurting the gut bacteria? I've become a big believer in, and we've raised our daughter kind of similarly, is to mostly organic, non-processed as much as possible.
Does it make a difference? Some people say non-organic is like not really different.
I'm not sure. I mean, it depends. If you're feeding animals antibiotics and hormones, I think that's definitely going to potentially increase your risk of cancer as opposed to having something that's grass-fed. I'm not saying just, and also limiting meat consumption, but I think there is something to that more natural way without pesticides, without hormones, without antibiotics. I think that all these antibiotics are probably killing our gut bacteria as well. So the processed foods, also the genetically modified wheat, I think all of these things have kind of wreaked havoc overall on the digestive systems. And then there's the water quality. I mean, I've been drinking filtered water. I've never liked the taste of tap water. I've always filtered it. I have one of these Zero Pures, and that's basically the water that I've been drinking. And but we know that there's cancer clusters all over, which could be related to the water, could be related to toxins.
Oh, geographical clusters?
Geographic clusters,
Interesting.
yeah. So I think diet is going to be key into reversing a lot of what's going on now, especially young women with breast cancer, these young patients with advanced rectal cancers. I think this is all tied in with nutrition, the gut microbiome, and one of the things that I've been doing for the last few years is I look up. I've been researching what are the best probiotics to take. No one really knows the answer, but I think the best answer is those that are just kind of natural.
That were
kimchi,
around 100 years.
Kimchi, kefir, kombucha, all of these things that were just there, not the capsules that you buy off the shelf, not the Dannon yogurt with all the sugar. I think all of this together has just created an environment where, while we've made a dent in reducing mortality from cancer, I think
that's after the cancer's there.
That's after the cancer's
right.
there. I think we're going to see that reverse because of obesity-related driven cancers, including liver cancer, and then also what I'm going to call is digestive-related cancers like colon and rectum. we know that that's having a dramatic impact. And that also goes back to training. Doctors don't know anything about nutrition. They don't know natural, they don't know organic, they don't know gluten-free, this and that. We weren't taught any of that. We were taught this is how much protein you need, this is how much carbs you need.
And this is how to get rid of the cancer.
This is what happens if you have vitamin B deficiency, this is what you get. If you have vitamin D deficiency, this is what you get. This is what this mineral does, this is what that mineral does. But never in understanding, because I don't think doctors then knew, the medical schools never knew, true nutrition is eating whole, natural, unprocessed, likely organic type of diet. All these fad diets are there. They don't last. They don't last. We were never taught any of that, and yet patients are coming into the ER with all kinds of problems associated with it. I'm like, what the hell are you doing? So there's definitely a lack of education, because I think there's a lack of knowledge. And I'd like to see, kind of a shifting of research dollars more into that kind of analysis of, study, because we got patients now coming, well, I'm going to do the herbal diet, I'm going to do alternative care, and I'm like, I can't tell you that it's going to work. And then the other big thing now is cannabis. Can I take cannabis? Can I smoke it? Can I eat it during the treatment? Can I do this? And and if patients are really having nutritional issues and stuff like that, I kind of say, look, I can't recommend it. I don't know the data, but if you've heard word of mouth, it does seem that this can help to alleviate some of those symptoms.
Is it alleviation of pain or symptoms, or does it reverse
nausea, cancer? They're looking into the anti-cancer effects, but right now there's nothing solid to say that it reverses that. It dramatically helps with the symptoms associated with chemotherapy, as well as pain, the nausea, loss of appetite, that sort of thing.
Cool.
Yeah.
As a cancer doctor, what are some tips that you could give people to prevent the onset of cancer? Because whenever someone gets it, they're like, didn't think it was going to happen to me, but it does.
Yeah. A lot of I'd say more than half of the cancers are lifestyle related. So these are things that people choose: smoking, drinking, bad diet, not exercising. So obviously not smoking, and I think all the smoking cessation programs have resulted in a decrease in cancer. Obviously controlling drinking, because drinking doesn't not only cause cirrhosis and liver cancer, it can cause esophageal cancer, bladder cancer, and mouth cancers as well. So
mouth cancers from alcohol.
Yeah, in fact, there was a study where they looked at alcohol-based mouth rinses versus not. There was like a 10 or 15% increase in mouth cancers because of the alcohol component in that.
Do you need to drink a lot to get a mouth cancer?
Yeah, but if you're doing it every day or 2 to 3 times a day, or it's just because you have that exposure there for a long time when you're rinsing, right, for a minute.
Wow.
So as opposed to just drinking, right, where it's there for 5 seconds, here you're rinsing and having a longer exposure. The other aspect is, diet. So whole, unprocessed, natural diet, organic, preferably avoiding junk food and processed foods, and keeping up with the screenings, obviously. Cervical cancer screening, mammograms, colonoscopies. Now, because of younger and younger people getting colon cancer, they move the age from screening from 50 to 45 now. So it's definitely had an impact. So I think proper diet, exercise, being healthy, limiting drinking, and then no smoking. That's the best things you can probably end up doing. And then also for avoid too much sun exposure, right? Sun causes skin cancers and increasingly melanoma, especially if you're much more fair skinned. So that also has to be. And so I'm not a big fan of people who use tanning beds. I think it just does dramatically increase the risk of skin cancers that way.
So with skin cancer, and we live in Florida, so it's very sunny, and I play tennis in the sun a lot. The purpose of sunblock, it's not to prevent tanning, it's to prevent skin cancer.
Correct.
Okay.
Yeah, the sunblock itself blocks the UV rays, and there's UVA, B, and C. And at one time they were saying, oh, it's only UVA, but it's UVB. They found out no, it's all the UV rays can cause cancer. And so using effective sunblock, I think like at least SPF 30, It's not to prevent the tanning, like you said. It's really to, and it's the UV that gives you the skin color too. So it does prevent tanning, but it's really there to prevent the cancer.
Okay. So as an oncologist, you've seen hundreds, thousands of patients.
Right.
What's it like to see someone come in at the maybe going to soon be in the mouth of death? You help them, you radiate them, and then eventually they're happy and they can go live and contribute to society. How does that feel for you?
So it's different for every patient, because it's one of, I know I can help, and it's one of, I don't know if I can do anything, and maybe if I did, I can make things worse. So it really comes down to, what's the indication. If it's somebody that has a bleeding tumor in the stomach, I can certainly give a few treatments of radiation and help to alleviate that. I'm not going to cure that patient, but I'm going to get rid of, nobody wants to have GI bleeding, and that will help with that. When someone has like painful tumors, like on the ribs or on the spine or on the hips, I know that I can give effective radiation to help alleviate that pain. So in that case, I know I'm going to be helpful. I'm a lot more excited and engaged that way. There are other times that we get asked to do radiation, especially for symptomatic relief. And in some cases, it's where tumors just didn't respond previously. And I'm hesitant to offer that, because all I'm going to do is cause a side effect without any benefit. And that's sometimes hard to tell a patient, like, look, I know it's indicated, but I don't want to treat you because it's not going to work. And sometimes it's not just battling the patient. Sometimes I'm having to treat the referring doctor, because just please treat that patient, do something, because I don't have anything else. It's like, at that point, it's hard to say who's going to have that, end of life discussion. So those kind of patients, they do, they humble you, because you know what you can't do. And it's the patients that that you can help that, do elevate you. So it really depends on the situation. But, when you can be of help, it's obviously very fulfilling. When you can't, I don't want to say you feel like a failure, but, it's like, your hands are tied and you just, it's not a good feeling.
I mean, then at that point, you just have to practice acceptance, I suppose.
Exactly. Yeah.
And what do you think is the most important ethical component of a doctor? Where do doctors stray, and where does that need to be corrected?
So I think that there's too much of a trigger, especially in the system we're in. I think it's driven for us to recommend treatments, and a lot of treatments. I think we're seeing now that less and less, and especially with radiation, we can give less treatments and still be as effective. And sometimes we don't need to treat. There was kind of had to go through this growing pains of prostate cancer, #1 cancer in men. All the screening was leading to very early detection of low-grade, low-risk prostate cancer. And enough studies were done to say, hey, look, you don't have to treat half of these. Doing the treatment is just going to give them much more side effects. They can live a long time with that low-grade, low-risk cancer, and nothing will happen. That's now kind of the standard of care. If we see somebody like that, that's like in their 70s, we're like, let's just watch this. We shouldn't do anything. And I think there are still doctors out there that are like, oh, no, you got cancer. We're going to have to give you the full course of treatment. I think that's the biggest hurdle we have to overcome, is that understanding that sometimes less is better and no treatment is better. Right now, the system is designed to kind of incentivize treatments.
Financially or pressure-wise from other people? Or?
Just, pressure-wise from system-wide. Even when doctors recommend treatments, they're doing the treatments, and then there's a component that, comes back to the doctor group, but there's a much bigger component that comes back to the hospital itself, because the hospital now has become this big bureaucratic administrative machine.
Money, you mean?
Yeah, money from the insurance companies and that sort of thing. So the hospital component is almost is triple, what the doctor recommends, does all this stuff, all the kind of cerebral work, But then there's all the technical aspects. It's the nursing staff, it's the machines, the maintenance of the machines, it's the all the staff behind that, and so that's coming back to pay for all that. So there's a huge component of cost that's associated with making these recommendations. It's not just, oh, I'm just going to recommend this, and there's a huge cost behind it that people don't understand. And that's all because of the complicated billing system, the way the insurance companies have been working with, with Medicare and Medicaid. It's you need a separate degree just to understand how all of that works. And we get asked by patients all the time, well, how, is this going to be covered? How much is it going to cost? And we never had training in understanding the billing. And because of that, I think there's been a lot of unintentional abuse because the system is so complicated. I think that's the biggest hurdle, is just simplifying the system in such a way that that doesn't happen. And there's been talk about trying to make it's like, you have this diagnosis, you get this much money for the whole thing, not a penny more. So whatever disciplines you need to do, this is how you're going to assign the money for the surgery, for the chemo, for whatever.
Oh, so then the doctor might want to do less.
Well, there's going to be that too, or it's like whatever you guys don't end up spending, that's what you can keep as revenue.
Mm-hmm. So, someone told me that it's not necessarily a good idea when MBAs run hospitals, because the MBAs are business people who got a business degree, they're familiar with business, and of course, as you just said, a hospital is a business. Mm-hmm. A doctor who actually knows all the components would be in a much better position to run a hospital.
Right.
But a doctor's not a business person.
It's funny that we're not business people, but we are now forced to understand the business side of things. Maybe not with the formal educational training, but one of the things, I think everyone knows that, if you treat enough patients, if you keep the cost low, then you get more revenue. I think that's just a basic, simple concept. Now, MBAs running hospitals may take it further and say, well, we can really reduce costs. We don't need this many nurses. We don't need this many therapists. We don't need, this. And then that puts a strain on the system, because now what you've done is affected the efficiency of patient flow through the system, because now you're taking away a lot of components that can help with that. And then that negatively affects the patient experience. But that doesn't necessarily always going to translate to the dollars and cents that the MBA sees, but from patient reviews and Press Ganey scores, there's multiple systems in this area, and they're all competing for the same pool of patients. So if one is offering a better patient flow and experience, that's always going to win out. And I don't see that translating, or MBAs necessarily engaging at that level to say, well, in the end it's cost, but in the end it's really about the patient experience.
So what could change to make this complicated system better? And you're someone who knows it from the doctor side, from the inside. Because you hear doctors complain about HMOs, and it's especially in the last 10 years, they get paid less for the same amount of work, they get more patients, and I think they think the only people in winning are the insurance companies, or how does it work? And also, what is the role of money within medicine? There's an idea as well, medicine is this noble act, and when profit and so forth gets involved with it, it can corrupt the intention, mess up the system. Now, on the other hand, you have costs. You need to pay the doctors well.
Yeah.
You need to incentivize people to do well and go to nice hospitals. So I wish they'll pay more. So where do we fall within all this?
So I think basically it's coming down to, and then I know we're trying to avoid politics. I'm not going to go down party lines here, but government getting involved always makes things more complicated. And so you basically have, government needs to have oversight versus free market principles. And I think there are a handful of practices that do practice the free market principle. They don't do anything with insurance companies. They, give the patient a bill that's, appropriate. When you start getting involved with insurance companies, there's a lot of additional bureaucratic costs. So those costs can kind of be eliminated in this free market system of, here's the bill, this is what we can charge, and then you can say, well, the, practice across the street is going to charge this. That kind of principle, the free market principle, if we are truly running medicine as a business, and I'm not going to deny it, there is a business component to it, having a free market kind of capitalistic type style may help to alleviate a lot of the abuses and over expenses and cost of medicine that way. The other aspect is from the pharmaceutical end, the United States gets charged 10 times more than the rest of the world, and there's this concept of, well, we're financing the rest of the world to get their medications because the governments around the world have really regulated the cost. And in fact, the pharmaceutical companies have a very large lobbying group in Washington, and so if you were to eliminate or be able to cut drug costs, I think that would have a substantial benefit in terms of how you could help control costs in medicine.
Does cutting the drug costs come from embracing the free market principle, or does it come from a government regulatory angle?
I think in that case, it's going to be both, because right now they are acting on free market principles here in the United States, but not the rest of the world.
Mm-hmm. And that's leading to,
that's driving
in this situation it's bad because the costs get higher. That being said, they make more money, they can fund more research, which then they can make better drugs and then export those to the rest of the world, which has it at subsidized
exactly
prices. So it's so complicated.
It is so complicated.
And so you think you've got the answer, but
the
then
way
there's
the government can
get
get involved in probably a beneficial way is to absorb a lot of the trial costs that the pharma companies have to put out, because they will have to pay tens of millions of dollars to get a clinical trial done right per FDA standards to get a drug approved. Mm-hmm. And maybe if the government were to absorb some of those costs, that could help to keep those costs down, because then you can drop the price of the drug and still the pharmaceutical companies can make a profit and still keep their R&D going.
Okay.
Right now, that's the big thing. We have to charge this much because we have a lot of research and development. We had to put tens of millions of dollars. And if they put tens of millions of dollars into a trial and the drug is negative.
Right. But that's why they need a lot of R&D money.
Right.
Yeah.
And, academic centers and universities and hospitals they have staff that help to work to keep all the documents for patients enrolled on clinical trials. And it's a rigorous process. And, it's like, that cost has to be covered somehow. And that's one of the major trial costs. And so some institutions are known to say, well, we'll open your trial, but you got to give us $20,000 per patient. And then other smaller practices say, oh, we'll do it for, $2,500 a patient. So it's a wide spectrum across the board that's driving up the clinical trial costs to meet very specific FDA standards for getting drug approval. And I think maybe that's where government should get involved, as opposed to just saying, oh, we're going to do Medicare, Medicaid, and is it Obamacare, is it single payer? I think, having some aspect of regulatory with the free market principle is going to work, but it can't be that we're the only country in the world with that free market principle, and the rest of the world is being able to benefit from that, but we're paying the tenfold.
It's because our companies here are doing the R&D. That's why the other countries benefit.
Well, other pharmas around the world. I mean, in Europe, they have their own R&D as well. But and it also depends where they run the trial. If they run the trial in India versus China versus some of these other places, as opposed to like Europe and USA and Canada, that's certainly going to help keep their costs down by running trials in those countries like that. But I think that's one of the biggest things. If they can keep clinical trial costs down, I think that can help to drive pharmaceutical prices down as well.
Which could end up making healthcare more affordable for more people also, provided there's not a universal healthcare system. Okay.
Yeah.
It's so multifaceted.
Yeah.
Because you have one principle of free market, you have other principle of government coming in to help, and then this can end up encroaching and making things worse, and this can end up leading to high prices that people can't access.
To kind of help simplify things, now hospitals basically have to come up with what they call as pathways. It's like, okay, if someone presents with this disease, we have it spelled out how they're going to be treated, what they're going to be treated with, and this is going to be the cost. And the insurance company will go, okay, if you abide by that pathway, we'll give you this much money. And so that's one way they're trying to help simplify the process, to make sure everything is standardized and done the same way with the same cost and the same, that sort of thing. And so, but coming up with the pathway, and each institution having their own pathway, I think is still not the answer. If you're going to do a pathway, it should be, this is one pathway that's going to apply to everybody. And then, the other thing too, is that, insurance companies are not allowed to compete across state lines. So that, if there's somebody in Georgia that has, the insurance is cheaper, and they'll give you, if you can do that and buy that, but we're not allowed to do that. You can only buy within state lines. So that, again, is not really free market principle.
Why can't they operate outside of state lines?
That's a specific rule, I believe, and I think the insurance companies like it that way because they get to then drive up, compete just within the state, not within the nation. And so then they can probably increase costs or increase, what you have to pay for insurance.
The margins,
yeah.
Interesting. Okay. So taking the conversation down to a more human level.
Yep.
If you had to give advice to medical students today, you're in their shoes however many years ago, what would you say? And let's say the doctor profession is going to get worse from the standpoint of more hours, less pay.
Yeah.
And let's just assume it will get worse. Is the calling worth it? What would make it worth it for someone to put in all the sweat?
So after all the blood, sweat, and tears, you get out into the job market and you don't understand billing. You don't understand contracts. People take a job that they sign the contract, maybe they don't read it, they don't have a lawyer look at it, and then it's got all these clauses in there, and basically it's like, oh no, you don't get a bonus, oh no, you're not working out, you're fired, and by the way, you have a non-compete clause, you can't work 50 miles around this area. They don't teach us about contracts. They don't teach about billing. And there's more of that going on in the big society meetings. I was brought up, I remember when I was a senior resident, went to the national meeting, they actually brought this up. It's like, you need to be educated on, when you're going to interview for a job, you need to have a lawyer look at that contract inside and out. You need to know every which way they can fire you, and if the non-compete is enforceable, and how you're going to be reimbursed, and what your responsibilities are. We had one day in residency where they brought in somebody from billing to explain, well, to bill properly, you need this component. They're like, what are you talking about? It's like, yeah, it's like you don't get reimbursed if you don't properly document. And so it's like, well, we got to document not just for the medical record, we have to document in a way that allows us to get reimbursed. That's lost in training. So I think what I would say is make sure you understand. The first thing you would do is when you are going to go interview for a job, get a contract lawyer. That's it. You need to get that. You need to be protected that way.
That is a very interesting piece of advice, which I wasn't expecting.
I remember when I didn't do that for Moffitt. I mean, it was a pretty straightforward, and again, I didn't have that knowledge, but I know when I took the job at Florida Hospital, I'm like, okay, it's private practice, I'm going to get a contract lawyer. And I got the contract lawyer, and he looked at the contract, he's like, wow, this is a fantastic contract. This is one of the better contracts I've ever seen. You should see some of the stuff I see from some of these small practices. So she's like, this is a good contract. You should sign it.
I think people who are fresh out of school, they'll sign any contract.
Oh yeah,
because they don't have experience, they have
Right.
no negotiation power, and they don't know what's
Right.
within the business aspect
Exactly.
of things.
And in academics, you're probably not going to have as much negotiating power, and they're less likely to pull a fast one on you. It's really in private practice where you might have say, and especially if maybe some of the group is older, some of the guys are retiring, they're going to need you. Then you have to identify what the negotiating power is. But a lot of us just don't understand the business concept. And I wish there was a course on that, and if they could find an online course or just any course on that to take it, it'll be very eye-opening.
Great.
Yeah.
Great advice as a unique angle also. Yeah. So what do you think about the importance of family within maintaining a life, maintaining a career? Starting with your parents, now to your wife and daughter, how has that affected your ability to do what you do, live the life that you live?
I'm very glad that they're a part of what I'm doing. I think they do bring a lot of sanity, especially you have a hard day at work, you have a hard clinic, you're dealing with life and death all the time. You need something to just kind of ground you. And I think having family in that regard, where they basically just distract you from your career life, where you can just kind of focus in on home life, is definitely a must. Now, let's say you're not married or don't have any kids. I would say definitely, find something as a release. Whether if you're going to travel or you're going to play sports or do something, you need something as a distraction.
And to make you a fuller human.
And make you
also.
a fuller human, and it makes you more empathetic too. Especially when you have kids and they're going through their growing pains, and it definitely has helped make me a fuller person. So.
Great. And do you love being a doctor?
I do love being a doctor. I love the profession that I chose. I have good days and bad days, but mostly good days. And I love the people I work with. And I think that's key. You have to be in a group where you respect your partners and you also respect the referring doctors, and I have that here.
Great. Well, I'm sure the world really appreciates all the service you've done in these decades, and thanks for coming on the show as well.
Thanks for having me. I hope I was able to provide some useful information.
Definitely.
Yeah.
And you're able to share your experience, and that's what matters. This is a show about professionalism. It's about humanity. It's about amazing people, and we talked about all of that.
Yep.
So thanks a lot, Dr. Shridar.
Absolutely. Thank you very much. Yep.